As you can see from looking over the shoulder of my next guest, Dr. Doug Lucas, there's a bone and a skeleton. He is as passionate about bone health as I am. And so this is going to be a really exciting conversation today that you're going to get a ton out of. He and I have been on a podcast Q&A together. He interviewed me for his podcast, which is amazing. Everybody should definitely check that out. The link to that will be in the show notes. And I heard an incredible talk he gave at A4M, one of the largest integrated medical conferences every year. Recently, I was there and he knocked my socks off. Today, I'm going to pin him down on a rather narrow band of information that I want to discuss with him regarding bone health, because as you know, from your listening to my podcast and your familiarity with my work, it's a big topic. We can talk about a lot of things, but his knowledge about hormones, HRT, and hormones beyond what people typically think about, just estrogen and progesterone, is by any stretch of the imagination better than anybody else I've heard talk about it in terms of practical terms, in terms of things that you can start doing right away, talk to your doctor about, or access more information through his resources. Doug, thanks for being here. I really appreciate it.
Thank you, John. That was really nicely said. I appreciate that.
So let's just give a little backstory so people understand a little bit more about you. I'd love to hear about your journey and why bone health and osteoporosis.
Yeah, thanks. And I'll end it with why I'm comfortable talking about hormones, because I started out in medicine as an orthopedic surgeon, and there are not a lot of orthopedic surgeons that are prescribing hormones, and certainly not talking about them on national and international stages. So, like I said, I started out as an orthopedic surgeon. I went through the osteopathic approach, always loved musculoskeletal medicine, loved the idea that we can literally, feel and manipulate as an osteopath. We can move bones and we can see results. What I loved about surgery is that we fix black and white problems for the most part, right? You have a broken bone, I can fix it, it will heal. What I learned though, as we went through that, is that, boy, bones are a really misunderstood system. They don't always heal. Sometimes they fall apart. There's this weird thing, osteoporosis, that nobody seems to understand. And so as I started my surgical practice, I got very frustrated very quickly because I felt like I was just cleaning up the mess of poor decision making, either by my patient or by my patient's care team. And so I've always been really interested in nutrition. My wife is a PhD and a registered dietitian, and is in the nutrition space. And I've always been impressed by the power of lifestyle medicine, nutrition, exercise, optimized sleep. Seen this in my patients and in my own life. And so I was very fortunate to be able to pursue that. So shortly before the pandemic, I left a conventional medical practice, went through additional training through A4M, like John just mentioned, that I now speak for, did an additional fellowship, board certification, and started a comprehensive style, prevention practice called Optimal Human Health. That was not focused on bone health out of the gate, but very quickly became focused on bone health because I do see that there is such a need to have this discussion. 10 million, supposedly, it's got to be a lot more, but supposedly 10 million people in the United States with osteoporosis, 200 million across the globe. I think those numbers are woeful underestimates of the actual severity of the problem. And nobody's having the right conversation. So now I'm really on a professional mission to educate the world that osteoporosis is largely preventable. It is oftentimes reversible if people are empowered and have access to the tools that they are able to utilize to help them to improve their bone metabolism. So we do that through a couple of different pathways. We'll talk about some of those today, but that's what got me to where I am. The hormone piece, though, it was interesting and unexpected for me. I was never planning on becoming a hormone, quote unquote, expert. But when it comes to improving bone health, hormones are a huge tool and they have to be talked about. And believe me, if I could find somebody else that could do it the way that it needs to be done for bone health, I wouldn't have done it. But we ended up creating a company specifically for mostly postmenopausal women initially, and then that became perimenopause, because hormone replacement therapy is not the same as hormone optimization therapy. The hormones you might get from your OBGYN or your endocrinologist are not necessarily what you need to improve your bone metabolism and to improve your bone health. So we had to do this through a different lens. And that led to a tremendous amount of research, writing a book, creating a company, and that company eventually getting bought by another company, because this is the way that we really need to do this for the population of women at large.
And expanding that access, I know, is something that you're really passionate about, as well as helping people, educating people, so they can have better conversations with their physicians as well, and make sure they're getting the right information, the right tests, and aren't missing really crucial components about this. Now, you and I kind of offline at one point, the C word can come up sometimes when it comes to osteoporosis. Can it be cured? How
Yeah.
can you say that it is reversed? I mean, you're a medical doctor. There's, medical doctors are, I think, very concerned about legal ramifications of saying something, regardless of what it is, can be cured, or we can actually reverse it. And because the typical management paradigm within conventional medicine is exactly that. It's managing a disease symptom, not necessarily focusing on the metabolism of the tissue, the physiology of this tissue, and trying to optimize that. So how is it that you are looking at this issue where you can be so bold, if I may, as to be using those words that so few other clinicians feel comfortable using?
Yeah, so this is an area where I just disagree with the way that we have a conversation around bone health in general. And it's one of the things I say in weekly virtual events that I do on stages. I say openly, loudly, and proudly that we can reverse osteoporosis. I'm comfortable saying it because I do it in my practice, right? I mean, I see patients who literally improve their bone density. They no longer qualify for the diagnosis, but that's not enough. And the reason why so many doctors, and again, I do these virtual events, and I always ask, how many of you attending have been told that osteoporosis is not reversible? And no matter how many people are on, almost all of them universally will say their doctor said that it's not. So there's actually literature that supports that statement. So the opposite of what I'm saying. There's studies that have been put out. These are not randomized clinical trials by any means, but these are opinion papers that have been published and peer reviewed, which would suggest that we should not consider osteoporosis, quote unquote, reversible, because it is just like any other chronic disease treated with a pharmacologic agent. And even though the T-score improves and you no longer meet the diagnosis criteria, you still have the disease because you are medicated for the disease. And then they lay out some great comparisons. So they use diabetes, they use hypertension or high blood pressure. And this is such a great comparison because it actually helps me prove my point too. So if you have somebody who has high blood pressure and you put them on a medication for high blood pressure, one or two agents, whatever it takes, their blood pressure is normal. Does that person still have high blood pressure? And the answer is, yeah, they do, right? Same thing. Somebody's diabetic. You put them on insulin or an oral agent, and their A1C, the biomarker that we use to diagnose the disease, it normalizes. But they're on medication. Does that person still have diabetes? Yes. So from that argument, you could say the same thing is true with osteoporosis, right? You have osteoporosis. You go on a drug, whatever it is, right? Prolia, reclassed, whatever it is. You go on this drug and your T-score goes from -3 to -2. Do you still have osteoporosis? Arguably, the endocrinologist would say yes. And their point in the paper was actually, if you were to remove that diagnosis, then your insurance company will no longer pay for your drug, and then you will actually have increased fracture risk. And again, arguably, this is all true. But in my world of prevention, my world of lifestyle medicine, if you want to call it that, if I have somebody who comes in to see me with hypertension, high blood pressure, if they also happen to be obese, if they also happen to have metabolic dysfunction, they have elevated insulin, they likely also pre-diabetic or diabetic. If that person changes their diet, changes the way that they sleep, improves the way that they move, and reverses those conditions naturally, meaning that their blood pressure normalizes, their A1C comes down, they're not on a pharmacologic agent. From my perspective, those things have been reversed. And I think everybody here would agree with that. So then the same thing is true with osteoporosis. If you come to me and you have a T-score of -3 and you improve the way that you eat, you improve the way that you sleep, you improve your hormone optimization, either with replacement or not, but whatever way that you can do it, and we watch your T-score improve from -3 to -2, do you still have osteoporosis? I would say that you don't. Does that make sense, John? What do you think?
Absolutely. No, I would agree with you. And again, I think that it's a paradigm and a conceptual difference between medicating somebody and assuming that they're going to be on this medication for life and working in a more holistic and integrative fashion where they're doing lifestyle changes, dietary changes, perhaps hormone optimization. And for me, the difference in those approaches comes down to, are you working with the body's
Mm,
biochemistry and helping move it towards a direction of optimal health? Or are you taking over and commandeering the biochemistry through a medication that typically is just targeting, one or a couple of pathways,
right.
and managing those pathways artificially versus supporting the body's natural ability to function as well as biochemically we can.
Right. Yeah. Couldn't agree more.
So in terms of the hormone piece, because I want to get a little bit of a deep dive here on the hormones. Talk a little bit about how you conceptualize hormones, because I think most people, when they think about hormone replacement therapy, and you already mentioned a different way to think about it, hormone optimization, but hormone replacement therapy, most people are just thinking about estrogen when it comes to bones.
Right. Well, and estrogen is a big player. We can't deny that estrogen is, of all the sex hormones, estrogen is the most well studied, although arguably I think it needs to be further studied from this perspective. But we know that estrogen is the biggest lever that we can pull. That said, progesterone, we know, has a role, and we can talk about that. Testosterone has been kind of studied, and we can talk about studies in men versus in women, but also just physiologically what makes sense, and then clinically what we see. And then it's really, for me, it's more of the combination of all three. How are we using these in conjunction with one another? What biomarkers are we looking at? And then we have to start talking about testing. That's a whole other controversial thing. But what are we looking at to understand that we are actually seeing the benefit of the hormones that we're using on bone specifically? What's so cool about bone, and John, I know you know this, but what's so cool about bone is that bones are telling us a story all day long, every day. There are things that we can look at in blood, potentially in urine, certainly in imaging. The bones are telling us what's happening. So we can actually tell whether or not we have enough estrogen in our body, not necessarily based off of the estrogen levels, but based off of what the bones are telling us. And this is one of the big things that's missing in this picture.
And that's the testing piece. So what would you look at in terms of a testing, an analyte, or what you would test to understand if a person has enough estrogen?
Yeah. So when we look at hormone panels, a lot of people ask, I get asked the question all the time, what estrogen level do I need to have in my blood to know that I'm protecting my bone? And the answer is, I don't know. There is some evidence to say that somewhere around 60 to 80 picogram per ml is sort of like the threshold. But what I can tell you is that I see women who have much lower levels, whose bones look great, and then ultimately imaging looks good down the road. I mean, down to like 20 picogram per ml. That's almost like a quote unquote natural level for a postmenopausal woman who's just getting a little bit of estrone converting into estradiol, right? It's a very low level. And then I also see some women that are at 60, 80, even 100 picogram per ml who are still losing bone with very high bone turnover. So there is variability, and some of the tools that we can use to further look at this is not just the estradiol level. I want to know that, but also what's happening with FSH, or follicle stimulating hormone. FSH will come down when estrogen rises, but it's not just the estrogen rise that does it. It's the feedback loop. So when the estrogen is having the impact on the cells that we want it to, FSH will start to drop. And this is why we can see, again, some women, FSH will drop to quote unquote normal. We use 30 as a measure, but it'll drop under that threshold even at lower levels of estradiol. But for other women, it might take 100, 120, 140 picogram per ml. So this is why we can't just go off of estradiol levels. And then the bones are telling us a story. Again, CTX, or C-telepeptide, is the osteoclast marker that we can look at in blood. It will start to drop once the bones see enough estrogen. And this is absolutely predictable. You see it in every study. And if you are on estrogen, but your CTX is still high, and by high, it kind of depends on the ratio here, but by high, I mean like 4, 5, 6, even up to 1,000, right? If your CTX is still high and you're on estradiol, you don't have enough estradiol.
In terms of estrogen, I just want to clarify for people listening, because I want to make sure they understand. People oftentimes use the word estrogen, but estrogen is a category of molecules. So could you really talk about, you also mentioned estradiol, the different types of estrogens and how, somebody looking at this and maybe concerned about their bones, is there specific subtypes of estrogen that they need to be concerned about, not concerned about, or
Yes.
focus on?
Yeah. So this is a really important topic, and thank you for helping me to clarify this. So sometimes I say estrogen, sometimes I say estradiol. I should always say what I mean, which is estradiol. That's what we're measuring in blood. That's what we're replacing when we are using a bioidentical form. We're generally going to use estradiol. But there are two other main forms that some doctors will test, some doctors will even replace with. So estrone is a different estrogen. It is not as bioactive as estradiol, meaning it's not as potent, but it is something that is contextually continued to be made in women after menopause, just not very much. But that's why if you test, you will see a signal that there is some estradiol there. There's just not much, and estrone can become estradiol. The other one that is really popular in more of the functional space is estriol. Estriol is a very weak estrogen. It is only present in women in any significant quantities during pregnancy. There was some push toward using estriol rather than estradiol in the early 2000s, and likely as a result of the fear around estrogen and estradiol and trying to avoid the potential quote unquote risk that was perceived at the time. But the challenge with this move, and I'm very I'm very frustrated by it, because this happens a lot of time in the functional space. You move away from the thing that's well studied to something that's less well studied in an effort to reduce the risk. But all you're doing is just moving into a more unknown space. So what is the risk of using estriol at any particular strength? We have no idea. It's never been studied, right? So you're moving away from the thing that has good studies because of the known risk, but you're moving into an unknown rather than into a safer thing. You just don't know. But you're moving away. You're like running with fear from the thing that you know, but you're moving into a thing that you don't know. There's one paper that I quote very frequently, and I can't remember the author, but they actually had different levels of estradiol. It was a dosing study for estradiol and bone health, which is why I talk about it. But what's really interesting in this paper is that they used estriol as the placebo arm. So technically not a placebo, but as the control arm, right? So the authors said it in there. They said, we used estriol because we know estriol does not have an impact on bone. And you could see it very clearly. I think it was a 2-year study, and you could see that predictable decline of the patients or the people in the study who were using estriol rather than the estradiol.
You mentioned safety. I'd love to touch on that a little bit, because after the Women's Health Initiative study came out, you would know better than I do when that came out. I don't remember, but decades ago, a couple of decades ago, maybe.
Yeah, it was 2002 was the first publication.
Yeah, and prior to that, hormone replacement therapy was popular, and then it pretty much fell off a cliff. And since then, it's been out of favor, and people are very afraid of uh, basically killing patients.
Right.
And now the pendulum has swung back. So what is a consumer of healthcare and somebody in the general public, what are they to make of this? Is it safe? Is it not safe?
Oh my
What do I
gosh.
do?
Yeah, this is one of the biggest questions that we answer over and over and over again, because the change in the perspective of hormones in the early 2000s as a result of the Women's Health Initiative, and not just that actually, but other studies that came out in that similar time frame, they were all asking similar questions around, could this potentially increase the risk of cancer? And what's interesting is that actually wasn't even what the Women's Health Initiative was about, but that's what the results became about. And I could get into a lot of detail. I could talk for an hour or hours on this, but essentially in the early 2000s, well, actually, I'll take a step back. Before that, you're right. Hormone replacement was very popular, and it was credited for doing a lot of things that maybe it didn't do. And so one of the reasons why they started the Women's Health Initiative was because they wanted to show, particularly from a longevity and heart health perspective, how good is hormone replacement therapy for heart health. And that actually is what the Women's Health Initiative was about, because there were lots of claims being made about longevity and the fountain of youth and like stuff that was arguably not true. The study, though, the way that it was designed had some pretty big flaws. And it wasn't even the design, I think, that is the worst piece of this. It was the interpretation of the data at the end. And the way that it rolled out, I go through this over and over again in my mind, and I just can't believe that we as physicians allowed this to happen. Because because I went through medical school. I started in 2005, so I was sort of in the early WHI period when I learned about hormones. And what I learned was estrogen causes cancer. Don't use it. Period. That's what the world that's what the world thought in 2005. But when the 2002 publication came out, they actually didn't even publish the article until after they had a press conference and they told everybody what to think. And this is the part that we should have been very suspicious about from the get-go, right? They had a press conference and they said we had to stop the study because there was an increased risk in the diagnosis of invasive breast cancer, the incidence of invasive breast cancer. And then also they talked about some blood clotting stuff and stroke as well. But that was the main takeaway. Hormone replacement therapy causes breast cancer. And that was it. And then they published the study online. But John, you and I both know that in 2002, we couldn't just go online and find a PDF of a paper, right? Nope. You had to be a member. You had to have access. There's no way that people could access this journal article. So nobody read it out of the gate. Eventually they did. When it came out in paper, they did. But by then it was too late. The change had already happened. And I've heard multiple people say this. I mean, this was by far the worst mistake that the modern healthcare system has ever made. The damage that was done, I mean, millions of women taking off of hormones, suffering from menopause symptoms, told that they can't go on hormones if they were starting to go through menopause, that they have to suffer because these things will kill you. You will develop breast cancer. You will die. And so they suffered. And millions of women have suffered and continue to suffer. Again, no question, the worst thing that the modern medical system has ever done. So now, 20 plus years later, we are backtracking on all of that. And there's plenty of evidence to support the safety of hormones in other studies, but you can even dig into the WHI and recognize the increase in the incidence in the initial publication is about the same as about 8 per 10,000 patient years increased number of cases of invasive breast cancer. No change in mortality or deaths. And that rate, 8 out of 10,000, that is considered an extremely rare or very rare potential risk that in most other studies would not even be mentioned, not even be talked about. It didn't reach statistical significance. We couldn't have even said at that time that it was real. Now, it did cross over the threshold of safety that the study was designed around. So them stopping the study was not wrong. Them having that press conference was not wrong. But the interpretation from the physicians is what was wrong. We all said, oh my God, it's going to cause cancer. We can't use it. But that's not what it said. It said there might be an increased risk. And then we had the opportunity 2 years later to backtrack on that because in 2004, the arm that was estrogen only, and to be clear, we're talking about conjugated equine estrogen, which is not a great product to begin with, but the estrogen only arm that didn't have the synthetic progestins in it showed nearly the same amount of protection from breast cancer. And yet in 2004, nobody came out and said, oh my gosh, what if estrogen actually protects from breast cancer? Because we do see that in studies over and over again. So we knew back in the early 2000s, everybody should have known this, that the devious molecule there with the progestins, the medroxyprogesterone acetate, the MPA, the Provera that was used in that study, because we see in every single study where they use MPA, there's an increased risk of blood clot, stroke, and breast cancer. So we knew then that it was the MPA, and yet here we are. And you say that we've seen a resurgence, not really. No. There's estimates to say that 40-50% of women who were eligible for HRT were using HRT before the Women's Health Initiative. Last year, the Menopause Society said it was 4%. I think they may have made that shift to 7% this year. We are still woefully undertreating menopause.
Well, and you've made a study of that. I'm just working off of more, anecdotal evidence of people.
I just can't, like, the reason why I started treating women with hormones is because when I started looking at the research, I could not believe how the medical community was treating women from a hormone perspective. I just couldn't believe it.
Well, currently the estradiol is FDA approved for the prevention of osteoporosis, but not the treatment of osteoporosis. You and I both know that there is research out there showing that hormone replacement therapy with estradiol does improve bone density and is associated with fewer fractures, lower fracture risk.
Yep.
The question I get quite often is, what if somebody, the recommendation is to start it during perimenopause, but what if somebody has gone through menopause and they're older than 60 years old? Because I've also seen recommendations in the research or conclusions in the research that we really don't know after 60. If you started after 60, we don't have data. And then you get into the potential risk could outweigh the benefits. And so it's generally discouraged to prescribe it after the age of 60. I'd love your take on that
Yeah.
research.
Well, this is so fun. And this, I get so worked up around this. I mean, I literally feel like I have the same energy right now as if things weren't going well in the operating room and I'm starting to throw instruments. Like I get so angry when I hear this, like, oh, well, after the age of 60, we don't know. So, I mean, let's go back to the study that blew it all up in the first place. One of the biggest trials, right? The Women's Health Initiative was one of the biggest RCTs on hormones. And even though, like I said, I don't think that Premarin and Provera, Prempro, they're not great hormones. But even in those trials, you could see that in that population on average, which their average age was close to 60, by the way, because they were over almost 10 years out from menopause, that group still saw a relative risk reduction of over 70% of hip fracture. So, I mean, tremendous benefit in that older group. And that's one of the arguments with the WHI, the way that they did it, is that they tried to design a trial where the women could not tell if they were on hormones or not. But if you're a symptomatic woman going through menopause, you're going to know if you're on hormones, right? So they had to wait until they weren't symptomatic, which means they waited until they were 7 to 10 years after the onset of menopause. So they were older to begin with. So we already know, or from the early 2000s, that this is true for this group. And then when it comes to the risk, again, we can look at the data from the WHI. Last year, they published the 20-year follow-up data. And doctors will always say, not always, I shouldn't say that in generalities. Doctors often say that if you're over 10 years out, the cardiovascular risk, the heart attack, the stroke risk goes up. That is true. But here's what they're missing. What they're pointing out is that if you were to start hormone therapy in the first 10 years after menopause, there is a protective benefit from cardiovascular risk. That's true, right? And we know that. This is the quote unquote magic window. If you go from 10 to 20 years out, though, even in the WHI's own data, there is no increased cardiovascular risk compared to placebo. So if that's true, what the hell are we doing? Like, why are we telling women that they're not candidates if there's no increased risk compared to placebo? Now, I get it. We can't go back in time. I can't tell you that it's protective anymore, although I think arguably it is. But I can't tell you based off of that study that it is. But if there's no increased risk from placebo, then what are we worried about? And I can tell you what they're worried about. They're worried about starting it and having a woman have a heart attack or a stroke, and then they're going to be blamed for it. This is why the guidelines have always said after 10 years, individual risk factors need to be considered. The guidelines never said don't do it. They said individual risk factors need to be considered. But I don't know about you, John, but clinically, my osteoporosis patients generally have very low cardiovascular risk, right? They are lean. They're generally relatively fit. They do not have metabolic disease. They do not have chronic inflammation for the most part, right? They have very low cardiovascular risk factors. So why are we not offering them hormone replacement therapy when they're 10 to 20 years out from menopause? I think that is another tragedy that continues to persist today.
Well, maybe it's because in most women in the medical appointments that they have and the physicians they're working with are not taking your integrative approach, and they're not getting the advice and the recommendations that you provide that help them reduce their cardiovascular risk. Because you and I both know that when you're following a bone healthy diet, a bone healthy lifestyle, you are not only improving your bone health, but reducing your fracture risk, but you're also reducing your cardiovascular disease risk,
Right.
cancer risk, dementia risk. I mean, just all the way down the list. It's all
Yep.
connected.
Yep.
Uh,
No, totally agree.
I've recently become really interested in the research on testosterone replacement in women. And that's because, of a personal experience with a frustration with the patient. And I'm not, seeing patients anymore, but who was going to a doctor and for perimenopause and was put on estradiol and was also having sexual dysfunction, low libido. And I asked the doctor, to consider testosterone, and she summarily refused it, even though I actually sent her a few, research studies on it. And so anyway, the patient switched doctors and found somebody who would work with her, and she improved in terms of the sexual dysfunction with testosterone in women. But it's controversial conventionally. And so I'd love your take on the research and see if we're aligned on that, or if you happen to disagree.
Yeah. I mean, do you want me to talk specifically for bone health or testosterone in general?
Well, it's really some. Let me rephrase then. The research recommendations and the endorsements are quite a few international groups that
Right,
endorse testosterone replacement in women, specifically for low libido.
right,
Not it doesn't affect um, you know um, vaginal health like estradiol will, but it does improve libido and mood.
right,
And libido is a psychological challenge as well, so not surprising that the mood improved. But a
right,
lot of doctors and a lot of patients aren't really aware that women still do produce testosterone, just not in the amounts that men have and
right.
can benefit from some. But a lot of physicians are not interested in looking at that in women as they're going through menopause. They just focus on estradiol if they're doing hormone replacement, because you have a clinical picture often where they're getting the symptoms of hot flashes and low libido is also occurring.
Always.
And so
Which does
they're,
improve with estradiol too.
yeah,
Yeah, this is. I mean, I love this topic, and honestly, I wrote a book on hormones, and the entire book originally was on testosterone, and then I realized I should probably add some comments around estrogen and progesterone. No, because I'm a big advocate for hormone optimization across the board, and while estrogen and progesterone have their own challenges, especially in women, testosterone is it's another really interesting conversation because there's so much stigma and negative thoughts around testosterone, even in men, right? Like in men, it's hard to get it. It's hard to get it optimized. It's a controlled substance. Like you can't get it unless your levels are really, really low, and then insurance doesn't pay for it. Like we say it's hard to get for women, which it is. It's actually still hard to get from men. And all these things need to be fixed. But what's interesting when it comes to testosterone in women is that there seems to be this refusal to have a discussion around the benefits of testosterone. When, as you said, women make testosterone too. I'll take it a step further. Not only do they make testosterone, if you were to average out the estradiol levels throughout the follicular and luteal phase for women, and then look at testosterone levels and adjust for units, so you're actually looking apples to apples, there's more testosterone than estrogen in a woman's body at any time throughout the cycle. So
I had
yeah.
no idea.
So it's not that they make testosterone too. No, it is actually one of their primary sex hormones. Now, I'm not saying it's more important than estrogen. I'm just saying they've got it, and they've got a lot of it for them. It's about a tenth of what we have, which tells you how important it is for us. But what's interesting, when you look at the symptoms of menopause and you look at the symptoms of aging in men, they are almost identical, except some of the hot flash and those things. But as we both lose testosterone, which we both do, right? Men and women lose testosterone. A lot of the symptoms of aging/menopause are very similar. And we know that in men, if you treat those symptoms with testosterone, most of them get better. We know in women, if you treat with just testosterone, a lot of those things get better too. So testosterone is a very powerful tool, but yet the research continues to just fail to look at the use of testosterone for anything other than sexual dysfunction. So the guidelines, when you look at it, are very, very frustrating because you have this international position statement, right? Susan Davis's work. And not to throw her under the bus, she's a very prominent speaker on testosterone, and these are her views, and she says them loudly and proudly, which is we should not use testosterone for anything other than sexual dysfunction, specifically HSDD, hypoactive sexual desire disorder. FSIAD is the new version in the DSM-5. But we should not use it for anything else because there is insufficient evidence to support its use. Partially because they don't study it, which is super frustrating. But once you actually create that language, nobody can study it. It's been pigeonholed into sexual dysfunction. So if you look at the research, what you can see from a sexual dysfunction perspective is that it's actually not even that great for sexual dysfunction. You see a lot of language right now that like, don't fall for the testosterone trap. It's not that good. Well, for the right people, it is that good. But generally the doses in the studies are too low. And this is why when you look at anything else, actually, you don't see much benefit because they're not giving them enough testosterone. It's true for men too. That's why in men, from a bone health perspective, we can say that it improves bone density in some studies, but not all studies, but it doesn't reduce fracture risk because the studies haven't been large enough and they're not giving them the right dose. Again, the difference between replacement and optimization. So for women, absolutely believe that it's beneficial. We see it clinically. It's hard to get. There's no product. It has to be compounded. Again, there's stigma, and it's a controlled substance. So from a telehealth perspective, in my world, I can only prescribe in about 30 out of the 50 states. So this is a massive problem. But I will say, for your audience interested from a bone health perspective, the research is not great. I was actually just looking, I was reading earlier today, the study from 2014 that I don't know how I never saw this before, but there was estrogen and progesterone plus or minus testosterone. And statistically, there was no benefit to adding the testosterone. Now, the trend is crystal clear in the femoral neck. You can see this deviation in the lines, right? But it wasn't a big enough study. And again, the dose was actually pretty low, but at least they measured levels and the levels were good. So I think the study just needed to be bigger. It was probably clinically relevant, but not statistically significant, if that makes sense. And this is what we see in the research around testosterone in women. The studies just aren't big enough. And they're generally not, they're not powered, they're not funded. There just doesn't seem to be interest in proving it.
And one of the frustrating things for me in men that come to me with already having had a DEXA scan and diagnosed with osteopenia and osteoporosis is their provider who was working with them didn't test their testosterone, didn't even talk to them about
It's
testosterone.
wild.
So I'm a big advocate of that in men who have bone loss to test the testosterone, but not just testosterone, their estradiol as well. So I'd love your perspective on that approach.
Yeah, this is a huge one. And I think when I say that there is a tsunami or a flood of osteoporosis cases waiting, I think a lot of it is in men. And we've historically said, oh, it's 1 in 4 men that'll see a fragility fracture, and we don't even the current guidelines for screening are screen men at 70 if they have risk factors, but whatever. No, I think that as we see a reduction in testosterone levels across the board for men for all kinds of reasons, you see a linear relationship reduction in estradiol, right? So men don't make any estradiol in any appreciable amount. All of our estradiol comes from testosterone conversion through aromatase, or at least backwards aromatase. And so we only get estradiol from testosterone. And if you look as testosterone levels decline, estradiol levels decline. I guarantee you there is a flood of young men, 30s, 40s, 50s, who have like almost subclinical low testosterone, totals in the 300, 400s, that have single digit estradiol levels and are losing bone rapidly. So I think this is a big problem that we're going to see more and more. I think we're going to see more fractures in especially young men. As we're kind of figuring out what's happening with HRT and hormone optimization in women, this is totally going under the radar.
And just to be clear, to bridge make the gap and make sure it's very clear for everybody, estradiol in men is just as important as estradiol in women when it comes to bone formation and bone strength. It's not the testosterone. I mean, testosterone does have some benefits, but the estradiol is I would say, tell me if maybe you disagree, the primary hormone in men as well, responsible for increasing bone density and maintaining bone strength.
Yeah, I think so. This is what I love about hormone optimization. This idea that look, they've always functioned together. The body has never said, we're just going to use one hormone. No, estrogen and progesterone exist together and they fluctuate together, right? Testosterone is more consistent, but it always has still balanced out the other hormones. So for men, you think about testosterone is mostly an anabolic hormone. Like we call it an anabolic steroid, right? It's an anabolic hormone. It will help to build. When it comes to bone, we know that it stimulates osteoblasts. It helps to osteoblasts to go from, the stem cell into an active osteoblast. It probably increases their function some. But we know estrogen works more on the osteoclast. It actually works on both. But estrogen also works on the osteoclast at a bigger level, right? So now we're slowing down that bone loss. We're slowing down the turnover. And when you have both in your system, you're working on both sides of the equation, and that's bone metabolism. So yeah, we definitely need both. And this is why I think some women do see tremendous benefit from testosterone replacement. Some men will see it, some men won't. It just sort of depends on what's that unique situation.
Yeah, amazing. I could talk to you for several more hours for sure, not just about this, but many other topics, because you are just, wealth of information and so well read in the literature. And
thank you.
You have a unique ability that's quite impressive to articulate the science and what you know in a way that's relatable and understandable to the general public. And I just love listening to you, and I really enjoy talking to you. How can people find out more about your work? Where would you direct them to do that?
Yeah, I mean, I think right now the best place, if you're looking for bone health information, is the YouTube channel. You just go to YouTube, look up the Dr. Doug Show. It's called the Dr. Doug Show: Bones, Hormones, and Health Span. It's all about osteoporosis and bone metabolism. And that's what we're really doubling down on. I love this stuff. So that's the place to go. I'll make a plug from a hormone replacement perspective to my current clinical role is as the VP of Health and Hormone Optimization at LifeMD, which is a large nationwide telehealth practice in the United States. And so we are building, at this time, this is a few months away from being released. So at this time, we are building and are scaling a women's health offer. We're going to reimagine the men's health offer. So hopefully by the time this comes out, we'll have both a women's health offer, a men's health offer that will really stand out from the crowd, as well as a bone program that will be specific for individuals looking to improve their bone metabolism. So hopefully all that will be available. We'll make sure you have the links for that.
Fantastic. So those two links to your YouTube channel, LifeMD, will be in the show notes as well. Thank you for spending some time with me. I learned a lot and I loved it. I always love talking to you.
Yeah. Thanks, John. I appreciate the opportunity.